Hi, good morning, all the participants. While I'm waiting for more participants, let me give a few a short introduction of Dr. Abdul Jabbar. He's currently working in a UMS as a specialist in charge to develop the upcoming intensive care unit for hospital UMS. And before that, he was working in a Queen Elizabeth II, a specialist in charge of ICU. For the education per se, Dr. Jabbar graduated the MBBS degree from Manipal University in 2010. After that, he has obtained his Master of Medicine in Anesthesiology from USM 2019. After that, he attained his postgraduate program in organ donation and transplant medicine from University Malaya in 2020. He's been working in Putrajaya, and after that, Queen Hospital, Queen Elizabeth in anesthesia and intensive care. So he's specialist in field of anesthesiology and critical care. So currently, he's also a lifetime member of the Malaysian Society of Intensive Care and Society of Transplantation. So, and then his main interests are the intensive care unit, intensive care medicine, organ procurement, and transplant medicine, in addition to the anesthesiology work. So, and his specialty interest in the ICU includes rehabilitation and mobility in ICU, sedation practice in ICU, sepsis and septic shock, ventilator desynchrony, organ donor management, and a point of care ultrasound in the ICU. So, yes, without further ado, we can invite Dr. Abdul Jabbar. Dr. Abdul Jabbar is all yours. Thank you.
Thank you, Dr. May. Thank you for the nice introduction. So I hope everyone is already in. I will start my presentation. I'm Dr. Abdul Jabbar. So I just recently joined UMS, and I hope you enjoy my talk today. So my talk is about post-operative pulmonary complications. Although it's related to surgery and post-surgery, I think it's involved everyone, and it involves all of us to increase the quality of care for patient undergoing surgery. This involves also medical specialists, rehabilitation specialists, and all other specialists and all medical officer and nurses, physiotherapists involved in the hospital. All are very much involved and to make this a success. Okay, so let's talk about what is the post-operative pulmonary complications and what is the role of rehabilitation. Okay, first we go to the outlines of my talk first. So first, I will talk about what is post-operative pulmonary complications, and perhaps a lot of you seem to have a bit of confusion and on what is PPC and what is not. So in short, in the syncronym for official syncronym for the post-operative pulmonary complication in the journal and writing is a PPC. Okay, so next I will talk about why PPC is important, and then what are the risk factors for PPC, and how can we reduce PPC from happening, and what is the role of rehabilitation, and how do we implement this in our upcoming hospital. Okay, so who needs to know about PPC, post-operative pulmonary complications? Number one, of course, is the surgeons, anesthesiologists, physicians, rehab specialists, physiotherapists, hospital administrators, and actually basically everyone in the hospital. Because management for patient in the hospital involve everyone, and everyone works as a team to achieve the better outcome for the patient. So when I go through my presentation, here are some quick guide to my presentation. So I put title for each slide and discussion on top, and the slide body for content discussion in the main body. So when you navigate through my presentation, the QR code available for each page with references for you to quickly snap photo and review yourself, because I don't want just to give reference down there just for to make it pretty. I just also want to show you, if you're interested, you can snap the QR code for faster link. Okay, and the section of discussion I will put on the bottom when we go through each section. So first, what is the post-operative pulmonary complication? So post-operative pulmonary complication actually have been this specific complication have been studied for the last 3 or 4 decades, and they have gone through many and many variation of terms and definition. And but the latest one, and all the perioperative enthusiasts or special interest group in whole world, in international, they have come up with the standardized endpoints for perioperative medicine. Step working group have been working to develop a lot of definitions in terms of perioperative outcomes. So one of it is PPC, and its definition is actually a composite of respiratory diagnosis. Okay, so if the patient develop pulmonary complication after surgery, so it can be classified as PPC. So what are they? They put it PPC as this diagnosis sharing common pathophysiological mechanism of respiratory collapse and airway contamination. Number one is the atelectasis, where there is a lung collapse, either alveoli or some parts of the lung or major parts of the lung, which is lung collapse, atelectasis. Number two is a pneumonia. They follow US CDC definition. Okay, as you can see, the lungs on my right hand corner is reduced, so it's a lung collapse. Number two is pneumonia, is infection after the surgery. The lung becomes red. And ARDS, basically this is the severe form of respiratory failure, which means the lung is very badly damaged and due to a lot of changes in the molecular level, causing very difficult ventilation and oxygenation. They follow the Berlin ARDS definition. And the number four is pulmonary aspiration. Okay, so they also standardize that whenever we talk about PPC, either is no PPC, none, or mild or moderate or severe. So none, which there is no PPC, prophylactic oxygen delivery. We usually after surgery we give patient nasal prong or prophylactic oxygen delivery. So if patient just have this just for prophylaxis, not for treatment, not for desaturation and so on, we don't call it mild, moderate, or severe. We call it severity is none. Okay, so if mild PPC, the patient require treatment of oxygen with FiO2 less than 0.6, and moderate PPC is FiO2 more than 0.6 and require a higher step of oxygen support, which is high flow nasal oxygen, or both. Okay, where means that he require high flow of oxygen, and it also require a fraction of oxygen higher than 60%. So severe PPC is when the patient is using unplanned use of NIV, CPAP, or invasive mechanical ventilation. So notable exclusions excluded due to is best to be evaluated separately. So previously PPC also includes pulmonary embolism, pleural effusion, cardiogenic pulmonary edema, pneumothorax, and bronchospasm. So as we go on further in the future, if you are interested in perioperative medicine research, the recommended definition you need to include all these five, because all these five is considered they can be best evaluated separately, and they do not share pathophysiological mechanism as the first four diagnoses, which is atelectasis, pneumonia, ARDS, and also pulmonary aspiration. So actually, how common are PPCs? Okay, so after surgery, is it common, or is it something that is very rare? So if you look at the literature, incidence of PPC ranging from 1%, low risk patients in low risk surgery for PPC, till more than 30% in high risk patients. Okay, it depends on what type of patients that are going for surgery. In a large meta-analysis, about 21,940 patients, there were 3,164 patients had PPC. So as an overall rate of incidence of 14.4%. Okay, that is actually quite high. Imagine 100 patients going for surgery, about 15 patients will get either pneumonia, atelectasis, ARDS, or aspiration. If according to the previous definition, this also include the other five: pulmonary embolism, bronchospasm, and so on. So incidence rate of almost 15% is actually quite high. So for a complication to have such a huge impact on outcome, because when patients have pneumonia, ARDS, and so on, the impact on outcome is very high. They have high mortality, high morbidity, prolonged length of stay, bad quality of life after surgery and even when they go home. And for these complications that have very high impact on outcome, an average incidence of 14.4% can be considered actually very high and very worrying. Okay, so next, why PPC is important? So why do I even choose this topic to talk to you? So PPC actually significantly increase post-operative morbidities. They prolong length of stay up to 2 weeks. Okay, imagine patient come in for a simple procedure like hernioplasty for a normal hernioplasty, and after that he developed pneumonia, he developed atelectasis, developed aspiration, and the length of stay can go from 5 days or 4 days, can go up to 2 weeks in order to treat all these complications. So it's actually quite bad lah. So it also at the same time when the length of stay is increased, it increase the healthcare cost up to 50%. Okay, so it also burdens the institution and the patient if the patient is self-paying, and it also increase hospital readmissions. And post-operatively, a lot of patients find it they have a poor quality of life after they went back home because of this post-operative pulmonary complication. And PPC also significantly increase post-operative mortality. Not only they increase morbidity, they also increase mortality. With a high short-term mortality, almost 20% of patients with PPC die within 30 days. Okay, so out of the 15 out of 100 patients going for surgery, almost 15 patients will get complication, and out of the 15 patients, almost about one fifth, about 3 or 4 patients will die because of PPC. This is very sad. So, in long-term mortality, more than 90 days, 400 to 500% higher mortality than the average baseline. Okay, and long-term mortality at rate are about 50 to 70% on average. For example, the 15 patients that develop PPC, about 7 or 8 will die in the end after 3 months because of the morbidities that they have after the surgery. Okay, so in a multi-center prospective observational study recently done in 1,202 patients in the US, they collect the data prospectively, prospective observational study. So about 33.4% developed PPC out of 1,200, and all of them that had PPC had 2 times longer ICU stay. So they are more likely to go into ICU to treat the complication, and they also stay 2 times longer than normal ICU patient. They also stay 3 times longer hospital stay. And among this PPC group, they had a 2.3% mortality, not so bad compared to the retrospective data. But the most important thing is, if the patient don't have PPC, they have 100% survival rate. Okay. So how does PPC occur? What are the pathophysiology of PPC? So PPC starts with atelectasis, and which is the lung collapse. And lung collapse leads to loss of lung volume. And at the same time, when the patient undergoing surgery, they have respiratory muscle dysfunction when the patient have PPC, and reduced mucociliary clearance. So all of this will cause atelectasis, lung collapse, loss of lung volume, respiratory muscle dysfunction, reduced mucociliary clearance. Okay, so if you can see the pathophysiology in the first 24 hours after surgery, when the patient go into the surgery, a lot of them will have reduced static and dynamic lung volume. So the lung volume itself will reduce because of the surgery, especially surgery involving thorax and abdomen, and also the anesthesia we need to use muscle paralysis and so on. Okay, respiratory and this can cause atelectasis. At the same time, respiratory muscle weakness and dysynchrony can occur because of the muscle paralysis, and reduce central drive to breathe because we give opioid, analgesic, and so on. This will reduce minute volume, and at the same time, because of anesthetic agent and a lot of drugs that we're giving during the surgery, and also because of the surgery itself, inflammatory process and so on, they can have a reduced cilia beat, mucociliary clearance, reduced cough strength, and reduced mucociliary clearance. Okay, so post-operatively, day 1 onwards, the clinical consequences, they can have segmental or lobar lung collapse. They can have ventilation and perfusion mismatch and inadequate gas exchange. They can have sputum retention, the sputum increase, one thing is sputum increase, and also another thing is the mucociliary clearance is impaired. So this can lead into pneumonia and other complication. And microbial contamination and immune system response is also will be impaired. And from clinical sign, you can have chest imaging changes, occultation changes, desaturation, tachypnea, coughing, increased sputum, yellow color sputum, positive culture, increased white cell, increased fever. And the clinical response, usually what we do is we give respiratory physiotherapy, we give high flow oxygen therapy, we give ventilatory support, we transfer to ICU, and we do mechanical ventilation. And many of time we need to give antibiotic to treat the pneumonia. Okay, so when we give anesthesia and we give paralysis, loss of chest wall compliance that keeps the lungs open, okay, will be lost during surgery. So this is the pulmonary compliance during when you are awake. When we are awake, if you remember the physiology, our lung is kept open, the alveoli all kept open because of the opposing chest wall compliant, because chest wall tends to go outward while lungs tends to go inward. So the compliance, the opposing effect of lung which tends to go inward and chest wall tends to go outward, which maintains our lungs at the best optimum compliance, which is this one, the solid color red color line. And then this respiratory compliance, because of the opposing chest wall and lung, keeps the lungs open all the time at a good FRC level and a good compliance level. And this makes our lungs easy to open, and once it when we exhale, it's easier to inflate it back. Okay, so when during anesthesia, this chest wall compliance mainly will be lost. Okay, because we give anesthesia also can cause smooth muscle relaxation and skeletal muscle relaxation as well. When we give paralysis like procronium and trachurium and so on, neuromuscular blocker, this also paralyze the chest wall, making the chest wall practically non-existent. So there is nothing to pull out the lung and keep the lung open. So the lungs, because of the nature of the lung tends to collapse inward and the lung will be closed. This is what caused the initial lung collapse changes in for patient undergoing surgery. On top of that, when the patient lies supine and the abdomen compress, the abdomen content and the diaphragm push the lungs up and causing further impaction on the lungs and causing compression on the lung and causing further lung volume reduction and atelectasis. And also at the same time, if the operation, the surgery involve around abdomen and thorax, this also complicates this even further, causing even more atelectasis and changes in the lung. So all these four factors takes into account to cause this post-operative pulmonary complication. So if you go into a deeper level, molecular level, the alveolar unit level, this translate into the net tethering stress. Okay, net tethering stress occur from the interaction between chest wall and the lung compliance, and because of the loss of the chest wall compliance, the tethering is reduced and making the alveoli collapse. Okay, and it gets deeper. Changes in respiratory compliance resemble obese patient changes, like I can show you just now. The obese chest wall is like this. It's almost like a obese patient. And PPC, these changes is actually more impactful and more pronounced in obese patient, because the changes is almost like in obese patient lah, when the chest wall compliance it gets lower. And we go into the deeper pathophysiology. Because of this loss of lung volume and the alveoli crushing on each other, this will cause biologic injury and cause inflammatory process to start and induce inflammatory process and causing local immune dysfunction. And all of this can cause the alveoli to have a lot of exudates and transudate, and causing the lung the alveolar deformity and causing the damage at the small alveolar units. So when more and more alveolar units are injured and inflamed, so this can cause further and further impairment of the lung function and also compliance, so will lead to postoperative pulmonary complication. So this is how post-operative pulmonary complication occur. So you may think on not all patient will have PPC. So otherwise, out of 100 patient, 80 or 90 patient will get PPC. Why only 15 patient get PPC? About 15 to 20% get post-operative pulmonary complication. So a certain type of patient will have a higher risk to get this PPC. Okay, so we go for the risk factor for getting PPC. So number one is a patient related and non-modifiable. So after 4 or 5 decades of research, we know now for sure, for very high confidence, is that elderly patients are more at risk to get PPC, and the age is more than 65 years old. And general health condition also predispose patient to have PPC, where ASA more than 2. Okay, so other smaller risk factor like male patient, malignancy, long-term steroid use, prolonged hospitalization, impaired cognition, impaired sensorium, acute and chronic renal and liver failure. So these are the non-modifiable post-operative risk factor for patients that tend to get higher risk of post-operative pulmonary complication. So the most important one is the age and also the overall general condition. So the more comorbidity that patient has, the more comorbidity that is uncontrolled. ASA, if for those of you who are not familiar, ASA is American Society of Anesthesiology classification. So they classify 1, 2, 3, 4, and 5. So the higher the number means the more comorbidity that the patient has. Not only the number of comorbidity, the comorbidity is not controlled. For example, a very bad control diabetes, a very bad control hypertension, very bad heart function. So the higher the number means the more comorbidity is not being addressed or being not being taken care of. Okay, so a poor treatment of the comorbidities. So how about the modifiable? Certain as of course, when you talk about pulmonary complication, of course the risk factor will be those who are having risk factor for the respiratory system, such as uncontrolled COPD and asthma, patients who are heavily smoking, and who have also recent respiratory tract infection. So all these three is a strong predictor of getting PPC and high risk factor to get PPC. On top of that, obesity, hypoalbuminemia, and malnutrition. These three correlates with the nutrition status of the patient. Patient who is malnutrition, either excess nutrition or low nutrition, and have hypoalbuminemia is also a risk factor for getting PPC. Okay. And in addition, preoperative shock and preoperative sepsis can cause patient to get a higher risk of getting PPC. And lastly is a congestive heart failure. So this bowl is the one that a high amount of evidence to show that there is the significant risk factor for getting PPC. So how about procedure related? So on top of everything, types of surgery is known to be the most important risk factor to get PPC. Of course, the type of surgery involved thoracic and upper abdomen is the highest risk factor for PPC because it involves the area around the diaphragm and area around the lungs. Okay, and head and neck surgery, neurosurgery, and vascular surgery. Okay, so as you can see, compared to the peripheral surgery like orthopedic surgery in the upper limb, lower limb, away from the diaphragm, because if away from the diaphragm and away from the chest, the risk factor of getting PPC is lower. A lot of things can explain this because nowadays anesthesia tends to get non-general anesthesia. So if the operation is doing on the arm or on the hand or on the legs, we tend to do regional anesthesia rather than general anesthesia. In addition, surgery away from the trunk will less likely affect the respiratory symptom compliance. And emergency surgery, and if the duration of procedure, especially general anesthesia, exceed more than 2 hours, the risk factor of getting PPC is getting high. It's making it higher and higher. And multiple surgery within same admission. And what is modifiable risk factor? Non-modifiable means you can't actually change the type of surgery. For example, you want to do heart surgery, but you can't change the location of the surgery, right? Okay, but certain things like general anesthesia is higher risk compared to regional anesthesia. This, in certain cases, we can modify to use a different type of anesthesia, like regional or neuraxial anesthesia. And open surgery is higher risk to get PPC compared to laparoscopic. And residual neuromuscular block, when we give paralysis and not using nerve stimulator to check the level and depth of neuromuscular block, and use of long acting neuromuscular blocking agent, and use of neostigmine instead of Sugamadex. Okay. So other smaller risk factor is perioperative nasogastric tube usage, intraoperative blood transfusion, improper mechanical ventilation strategy, and preoperative anemia. And can we actually predict PPC in patient going for surgery? One of the most famous predictor of PPC is the ARISCAT score. These are the score that you can see here. Age less than 50, 0 score, and 51 to 80, the patient will get 3 score, and age more than 80 will get 16 score. So all this score, if you can see here, respiratory infection patient will, like I told you just now, respiratory infection is higher risk to get PPC. Preoperative anemia also higher risk to get PPC. Surgical incision is the most important, upper abdominal, intrathoracic, and duration of surgery also is very important. So more than 3 hours, the score gets even higher. And emergency procedure also is a risk factor for PPC. So ARISCAT score has been used in a lot of research. It's one of the most extensively studied and validated score in post-operative pulmonary complication. So it was initially produced in a study in Barcelona, about 2,464 patients. Over the years, this assessed respiratory risk in surgical patients in Catalonia. ARISCAT undergone plenty of external validation and shown good discrimination and prediction of PPC incidence. And the score, if the total score of less than 26 patients is low risk, means they have 0.7% rate of PPC. 26 to 44 means moderate risk, 6.3% rate of PPC, and more than 45 is high risk, 44.9% rate of PPC. So how about other scoring system? Since invention of ARISCAT scoring, many other scoring exist. Some of the popular ones are Periscope, MRPT, Sleep2, Las Vegas, PPRI, and Aurozula score. ARISCAT still considered the most reliable with the most external validation done to date. And ARISCAT scoring has also been validated in population in Asia, China, Thailand, Indonesia. Malaysia, I can't find any validation yet. Maybe one of our brilliant researcher in UMS can do for validation for this ARISCAT score in Malaysian system. And we have talked about the PPC and the risk factor, pathophysiology, and so on. What are the perioperative intervention to reduce PPC? So in this very large systematic review and meta-analysis, which is also recently published in 2021, last year, they talk about what are all the perioperative intervention for prevention of PPC, and what are the level of evidence for each, and what are the impact size for each intervention. Okay, this is the biggest meta-analysis, 27 years of data from 117 trials enrolling about 22,000 participants, investigating 11 categories of intervention. So these are all the categories of intervention that they studied. So if you can see, a lot of intervention that have been studied to reduce PPC, such as enhanced recovery pathway, which is ERAS, prophylactic mucolytics like a bromhexine, post-operative ventilatory support, CPAP, NIV or hypoflow cannula, lung protective ventilation, intraoperatively the mechanical ventilation strategy, respiratory physiotherapy. This is what we're going to talk about today. Epidural analgesia, goal-directed fluid therapy, incentive spirometry, inhaled therapies, in addition to usual drugs, smoking cessation. Okay. So 11 groups of intervention being investigated. We will go through the summary of intervention its effectiveness, but the role of rehabilitation will be discussed in more detail today. Okay, so if you look at this forest plot in the meta-analysis, you can see that this part is favors intervention from ERAS until smoking cessation therapy. So prehabilitation involved, when I talk about it later, it will involve respiratory physiotherapy as well as smoking cessation. Especially for the respiratory physiotherapy prior to the surgery, it seems to have a great impact on reducing the PPC, and all the other intervention also seem to give a good impact. ERAS is one of the highest impactful strategy to reduce PPC, and prehabilitation is actually part of the ERAS pathway. Okay, so as you can see here, okay, I will move on to the uh, talking about prehabilitation. So what actually is prehabilitation? When the patient have an event that occur, be it like a stroke, like an intervention treatment procedure or a disease. For example, patient undergoing for surgery, like patient undergoing surgery, undergoing chemotherapy, undergoing any procedure. This is what we call an event. Or the patient will have the disease like a stroke, especially stroke, MI, and other event like fracture or fracture and so on. So after an event, when the patient have some intervention, treatment or procedure, or patient have disease like stroke, rehabilitation is being done for the patient is defined as a set of intervention designed to optimize functioning and reduce disability in individuals with health condition in interaction with the environment. What is prehabilitation? Prehabilitation is defined as a set of intervention that prepares patient for known interventions or treatments with the aim to reduce complications and improve outcome. So one we do after the event, another one we do before the event with the aim to reduce complication and improve outcome. So we know what patient to target because we know which type of patient that is high risk, and we know what is the physiology, and then we give a set intervention that prepare the patient to reduce the complication. So usually, this prehabilitation is being famously quoted and written up for pre-operative period and pre-chemotherapy period because they want to buff up the patient prior to an known event that patient is going to have, and before they go to the event. Okay. For example, rehabilitation is post-operative period. Usually after the event of the operation, a patient have atelectasis or pneumonia, and then we can give respiratory physiotherapy, which is post-operative period, and post-disease period. Post-disease period like I said lah, stroke and so on. So prehabilitation actually involve from starting from prehabilitation, pre-operative and after operation, which includes all the peri-operative period. So what is this prehabilitation concept? So post-surgery, patient will experience drop in functional status and independence. If you can see here, functional status go up. The purple line. So this is a normal patient. When the normal patient, this is the pre-operative area period before, if the patient is not undergoing prehabilitation. After surgery is done, an event, the functional status and independence will drop. Okay, so this purple color, they will drop, and also after recovery and uh, exercise therapy and so on, they will go up back again and get to the level of dependency again. Okay, so this is the drop. After the drop, recovery will occur, speed of it and return to baseline, the purple line, depends on pre-op condition. Okay, so prehabilitation patient underwent increased functional status to better weather the storm. So if you know certain risk patient with risk factor like B, patient in green color B, patient in with higher risk factor to get PPC, they will drop, the functional and independent will drop, and but they will recover slower than the normal patient or patient that don't have a higher risk of PPC. They will recover slower, and most likely they either return back lower than the usual functional status, back to the lower than baseline, or they may not even back to the baseline, and they may need dependency to other family members. Okay, they may not have this cross the line of dependency. Okay, so however, if we give prehabilitation to the patient, a set of intervention, so when the patient have a drop of function status and independence, the drop will not be that much. It will drop until here, and because we increase the baseline, when increase the baseline function status, when it drop, it doesn't drop that bad, and when then it will can increase back up and probably higher than the usual baseline functional status of the patient. Okay, so this is the beauty and the importance of prehabilitation. We push and beef, we make the patient stronger prior to the event, prior to the operation. Okay, they have a better chance to return back to 100% functional status or even better than 100%. So who should be involved? Everyone. This is the patient. These are the prehabilitation concept. So anesthetist, surgeon, perioperative physician, medical physician. surgical, nurse practitioner, geriatrician, occupation therapist, public health staff, general practitioner, primary care nursing staff, everyone plays a role. Exercise, these are the five category of prehabilitation. Number one is okay, so these are the triad of the prehabilitation. So the first triad is cognitive and behavior, psychology, health psychologist, behavior psychologist, alcohol and smoking reduction. So these are the cognitive and behavior triad, cognitive and behavior section. Number two is the nutrition, and number three is the exercise, which is the respiratory physiotherapy. So everyone should be involved in order to achieve prehabilitation. So these are the tiered approach suggested by this author. And what are the cognitive and behavior prehabilitation that we can do? Number one is correction of unhealthy behavior, and also preoperative education. Okay, so preoperative anxiety, the prevalence is about 40 to 60% children. So imagine when you are going for surgery, a lot must go through your mind. You must feel very anxious. You must feel a lot of patients have fear, anxiety, isolation, frustration, exhaustion, or deterioration. So I also did my surgery about 2 years, 1 year plus ago. Although I work every day in the OT, in the ICU, and so on, I do have a preoperative anxiety. I also worry what is the problem in the intraoperatively and so on, because I know more about anesthesia and the complication. So I become more anxious than other normal people. So the normal patient, you can imagine they are very anxious. So the prevalence up to 40 to 60% children, about 11 to 80% adult. On average, 24% patients suffer severe preoperative anxiety. In an interview research, all preoperative patients preferred for a proper structured prehabilitation or preparation program. So they say preparing will have been better than just waiting. Okay, so we want to prepare them psychologically, and we want to make sure they know what is coming. Before surgery, the patient say, partner with me to help me prepare myself mentally and physically, offering support, preparing me and my family to recover at home, explaining surgical expectation, and so on. So we need to do more about preoperative education to the patient to improve this anxiety and in the patient going for surgery. So these are all the interesting research done preoperatively for prehabilitation. You can snap the QR code here, and these are what they suggested that we should do, like optimize my mental state, integrate eras, optimize my physical state, include support from my peers, prepare me to recover at home, be a partner, not only a doctor, be a partner with us, focus on my personal recovery goal, and so on. Okay, so a comprehensive review conducted on the current literature shown how should we deliver this preoperative education. Preoperative preparation video is the most effective intervention. For this group of research, they do a video, like for example, when the patient go to anesthesia clinic or the surgical clinic. So we show them a video on how is the OT looks like, how they will go through when they reach the ward, when they go to the ward, what they will experience, how the journey from the ward to the OT, what is inside the OT, how the OT looks like. It's like a video being done to show them, to prepare them on what they are going to encounter when they go for surgery later. So this is very important, especially for the patients that is first time going for surgery. Most of the patient is first time going for surgery. So this preoperative preparation video is the most effective intervention to improve this preoperative anxiety. Cognitive behavioral therapy shown significant improvement to reduce preoperative anxiety and depression. This is especially important for patients that have already have a pre-baseline problem with anxiety and depression. So CBT is most significant intervention to reduce this preoperative anxiety. Spiritual and religious intervention can reduce anxiety in Muslim patients. Music therapy have been studied extensively with proven benefit. These are some of the things that we can do to improve our preoperative education, to improve the anxiety, and in the end to improve the post-operative pulmonary complication. So it's very, sometimes we can't really we think until like that. So increased preoperative education can lead to reduction of post-operative pulmonary complication. The next one is the more important one, is the correction of unhealthy behavior, cessation of smoking, increased physical activity, and reduction of alcohol. So number one, especially for elderly patient and patient that are having physical inactivity, we need to increase the physical activity. Poor physical fitness predict poor operative outcome. Objective assessment includes CPAT, cardiopulmonary exercise test. We want to know how fit is the patient. We want to assess a VO2 max, anaerobic threshold, CO2 clearance, and so on. And alternative to that, if we don't have CPAT, it's a 6-minute walk test, incremental shuttle walk test. Intervention usually possible within pre-operative time frame, 4 to 6 weeks. We can do combined program to increase aerobic capacity and increase lean muscle mass. Components should be prescribed, monitored, and adjusted based on repeated objective fitness assessment. Okay, so if we talk about smoking, what is the impact of smoking on the perioperative outcome? The greatest impact of smoking is on chest complication. So these are the meta-analysis done, the forest plot done for the complications, post-operative complication in smokers. If you can see here, if patient is a heavy smoker prior to op, when they go to surgery, the greatest impact is on chest complication. Increased complication overall by 15%, increased mortality by 22%. So as you can see here, chest complication is the highest among all other complications and the patient going for surgery. So when the patient going for surgery, if the patient is a smoker, they have higher risk to get all sort of complications except the eye and probably face, mouth and neck. Other than that, is very very high risk of complication, and the highest among all is the chest complication. Okay, so we need to ask the patient to stop smoking at least 4 to 6 weeks before the operation. The greatest benefit of smoking cessation that can be seen is when smoking completely stopped more than 4 weeks from date of surgery. Okay, so this is the reduction of the risk going up, and then at the 4 weeks and above, the risk significantly reduced to get chest complication PPC after surgery. This is for the cessation of smoking. Preoperative period also have been found as one of the golden moments to encourage patients to stop smoking indefinitely. So, in many research have shown, when you ask patients to stop smoking prior to surgery, they will continue to stop until the rest of their life. Alright, so a recent meta-analysis and systematic review was done to assess the best intervention to stop smoking in preoperative patient. The most important one is to provide information on consequences of smoking and smoking cessation. So we need to do more on the education to tell the patient that smoking is not good, is bad, can lead to complication and so on. Preoperatively, we ask them to stop smoking for 1 month, more than 1 month, and most of the time they will be okay with it and they will do it, and it's the best intervention to stop smoking. The research is quite good to learn more about how do you stop smoking preoperatively. Other factors that have been found to improve success: longer delivery of intervention, face-to-face delivery compared to computer software, tool or telephone call. Challenges in Sabah include patient live in remote area and difficult transportation. So patient just cannot come for face-to-face intervention and counselling. Sometimes because they live very far away, probably maybe interview and intervention via online video call, Zoom or Webex or Google Meet maybe can be beneficial. I don't know, maybe. This may be a potential area for research to correct unhealthy behavior in cessation of smoking in preoperative period. So how about alcohol? Reduction in alcohol also have been shown to improve the post-operative pulmonary complication. Hazardous alcohol consumption may affect up to 22% of surgical patients. There is an established dose-response relationship with perioperative complication beyond 2 units daily. Patients with manifest features of alcohol dependence require specialist operative support. Okay, patients that have a heavy drinker can have elevated surgical risk without any features of dependence or organ dysfunction. So, alcoholic patient also tends to have higher post-operative pulmonary complication, and we need to correct this unhealthy behavior. So, alcohol consumption affect post-operative outcome via reduction in immune capacity, subclinical cardiac insufficiency, affect hemostasis, endocrine cell response to surgery significantly increase, and the most marked changes in the concentration of epinephrine, norepinephrine, and cortisol. So these are the ways that alcohol can affect post-operative outcome. Okay, so what are the times that required for the patient to stop drinking prior to surgery? So it has been found out on average we need about more than 4 weeks, about a month as well, to make sure the patient have reduced probability in getting post-operative complication. So it's about both smoking and alcohol consumption, we can ask the patient to stop about 4 weeks before the operation. So intensive intervention of complete cessation of drinking shown to greatly reduce post-operative complication, about odds ratio of 0.22 in favor of complete cessation. So it's actually very quite impactful when you ask the patient to stop drinking prior to surgery. So how about malnutrition? Malnutrition is a unbalanced nutritional state. So this is the second facet in the triad of prehabilitation. Okay. So undernutrition or overnutrition, it may involve micronutrient deficiency or excess, like obesity. Surgical stress causes catabolic metabolism in a patient will involve mobilization of energy reserve, glycogen, adipose, and lean body mass to maintain energy processes, repair tissues, synthesize proteins involved in the immune response. Okay, so when the patient going for surgery, this catabolic metabolism causing the resources of the patient being used up, like glycogen, lean body mass, protein, muscle tissues, all being broken down to supply the body to maintain energy resource process, repair the tissue, and synthesize protein for immune response. Okay, so when you talk about nutritional effect for postoperative pulmonary complication, meta-analysis have shown that malnourished patient had a pool OR odds ratio for post-op mortality higher at 3.61. So those who are malnourished going for surgery, they have higher risk of death. And according to the other nutritional criteria, GLIM criteria, just now was NRS 2002. Malnutrition also have been shown to increase PPC and mortality. If you screen the malnourished according to GLIM criteria. So relative risk about 1.6 to 2. Screening for malnutrition is important for patient undergoing surgery. For undernutrition, mass screening tool can be used, or Duke Preoperative Nutrition Score. For patient with obesity, in terms of malnutrition, specific condition called sarcopenic obesity carries a greater risk. It's not only obesity, it's sarcopenic obesity, means the lean body muscle mass is low compared to with the proportion ratio of fat and to mass to muscle is very high. Okay, this is usually obese in elderly patient. Dietitian plays a central role in optimizing malnourished patients. So dietitian is a very important person to be involved in prehabilitation to improve the nutrition of the patient, to beef up the patient prior to operation. So these are the example of MUST score, MUST, where we screen via the BMI score. This one for undernutrition, malnourished, weight loss score, and acute disease effect score. And after that, we need to stratify the patient, medium risk or high risk. So high risk, we need to treat, we need to refer to dietitian, and we need to give an intervention with a specific goal and to improve the patient well-being and nutrition prior to surgery. So these are the Duke pathway. So you can take the picture and the QR code. So as you can see here, they do take this nutrition very seriously in this hospital. So last one in the triad of prehabilitation is the respiratory physiotherapy, and I think this is the most important one. So respiratory prehabilitation is a method employed since 1990s in the USA to prepare patients for surgery to improve their respiratory muscle strength. This is important to be done preoperatively for patients to be able to do post-operative breathing exercise adequately. Okay, so we teach them preoperatively, we strengthen their muscle preoperatively, and we teach them on what to do after the operation, so they can do all these exercises adequately. So as post-surgery period associated with loss of lean mass, especially respiratory muscle, it is important for physiological reserve of muscle mass and strength to increase prior to surgery. Okay, so the muscle mass of the respiratory system, like diaphragm, the chest muscle, and so on, we want to increase the muscle mass, hypertrophy, hyperplasia of the muscles to make them stronger in terms of respiratory muscles, so that when the surgery comes and the post-operative period comes, it is inevitably those muscles will be lost slightly because the body is using up as protein to improve the repair tissue and also immune response. So when they have a higher muscle strength preoperatively compared to baseline, so when they develop the surgery and the insult, the impact will not be as bad as if they don't go for prehabilitation. So respiratory physiotherapy involves preoperative education and inspiratory muscle training. So this is and also we need to teach them incentive spirometry and also deep breathing exercise. These are the 4 aspects to be involved in respiratory physiotherapy under prehabilitation, respiratory prehabilitation. Okay, prophylactic respiratory therapy as part of prehabilitation have shown an effective, consistent 25% relative risk reduction of PPC, which is quite high. One quarter of our patient will be safe from PPC if you do this, and they also significantly reduce post-operative respiratory infection. Okay, so this preoperative education and inspiratory muscle training, and also deep breathing exercise and incentive spirometry. The first two are intervention proven to reduce PPC on mortality if done before surgery, and the other two is intervention proven to reduce PPC and mortality if done after surgery. Because so these two will be done before surgery, and these two will be done after surgery. So these four has been found out to improve and reduce PPC, improve the outcome. Okay, so but these two, the deep breathing exercise and incentive spirometry, training the patient on how to use the spirometry, it is crucial to be educated before surgery. So this is the part of preoperative education, to teach the patient on how to do deep breathing exercise and incentive spirometry before the operation. We teach them for them to do after the operation. Okay, and inspiratory muscle training is to improve and increase their respiratory muscle strength and the amount of muscle and also the strength of the muscle. So it's crucial to be educated before surgery. This is why the preoperative education. So what is this inspiratory muscle training? This is a simple device, a threshold IMT produced by Philips. There is also a lot of other. The Philips was the first one to make this, and after that there are a lot of brands that also do this inspiratory muscle training device. A very simple device that have been extensively studied in the past decade. One of the most significant intervention that can be done preoperatively to reduce PPC and reduce mortality in post-operative period. So meta-analysis shown significant reduction of PPC when IMT is being used as respiratory prehabilitation prior to op, with a relative risk reduction of 0.5. Okay, so you can see here. So reduction IMT reduce PPC. Okay. It also has been shown to reduce length of hospital stay by 1.4 days when IMT is being used as a respiratory rehabilitation. So you can see here, this is the effect of IMT. Benefit of IMT training is induced skeletal muscle morphological changes, including myofibril hypertrophy and increased proportion of type 1 slow twitch non-fatigable muscle fibers. So this is the type 1 muscle is more important in the diaphragm because it's a longer duration of action and it's non-fatigable, so it can work more and better after the operation. So other effects include autonomic cardiovascular system, minimizes peripheral muscle contraction during physical activity, enable exercise at higher intensities, lower blood lactate level, and improve sport performance. In clinical population, meta-analysis clearly support IMT, improve dyspnea and exercise tolerance across a broad range of conditions. So this actually also important not only in the perioperative period, it's also important in the non-perioperative. It's a medical condition like COPD, heart failure, stroke, critical care, and chronic kidney disease. So some of the famous training protocol written by Vakanet in Prepare trial adapted from Bailey protocol for loaded IMT training. Loaded IMT training means the loaded, we give a patient some load, some resistance for the patient to breathe in, to fight the resistance. So patient like a weightlifting, but this one is weightlifting for the respiratory system. So you weightlifting to build the muscle, you do in the gym to increase all the muscle. But for a patient going for surgery, the muscle that is very important, especially in high risk patient, is the respiratory muscle. These are the weight machine for respiratory muscle. At the start, we measure the maximal inspiratory pressure. We adjust the inspiratory load at 60% of MIP. Load is increased based on the rate of perceived exertion. So when patient score and RPE below 7 means they are already get used to the load, we increase the load by 5%. Okay, patient have to complete 30 dynamic expiratory efforts twice daily for 2 weeks. So for 2 weeks before operation, they do it 2 times a day. There are many variations of training regimes preoperatively with similar effects. So come to the end, what are the conclusion? Physiotherapy for me is, especially the physiotherapy part, prehabilitation is very important. Especially the physiotherapy part is extremely crucial. It's not only, I'm a strong believer of respiratory physiotherapy and mobility for preoperative and post-operative period. Preoperative for prehabilitation, post-operative for rehabilitation, for patient to improve back and return back to their normal state and normal functional status. In intensive care unit, immediate and during intubated and after extubation. Okay, so these are examples from my previous ICU. So there are no excuses for enhancing physiotherapy in the hospital. So like this patient I do in ICU, physiotherapy. Okay. So these are the incentives parametry we use, and these are the patient intubated. We mobilize them, we sit them up, we make them work hard. Okay, because they have lung issue, that doesn't mean they can the other parts of the body need to be paralyzed. Okay, if the respiratory system affected, why there is a need to mobilize?
Yes.
Laju lagi.
Sangat-sangat bagus. Lagi-lagi pakcik, lagi-lagi.
So this patient is on an IV, then we bring them down. Okay, we push all the machines together. So these are some of the respiratory aggressive physiotherapy that we do in the so patient intubated also we do mobilization.
Mau tinggi kah bagi atau mami sudah?
Saya rasa memang sudah.
Okay, if respiratory physiotherapy rehabilitation can be done in intubated and weak patients in ICU, why we cannot do prehabilitation in preoperative patients, especially those in higher risk of getting PPC? So there is no excuse not to do this for our upcoming hospital. So how do we implementing in practice? Requires multidisciplinary collaboration. All the physicians need to be involved. You have to remember back the triad of prehabilitation, cognitive and behavior, nutrition, and also respiratory physiotherapy. And also we need to include all this preoperative education like interview, video, music, spiritual, hypnosis, and so on. Okay. So the conclusion, post-operative respiratory complication can lead to prolonged length of stay, lower patient satisfaction, increased healthcare costs, and more importantly, increased mortality. So structured evidence-based interventions are important. Prehabilitation is effective, but other intervention that I have been shown you just now, other than prehabilitation, also are at least equally effective, if not more effective than prehabilitation. Okay, so things like ventilation strategy in the operation, ERAS pathway, and all sort of other intervention are at least equally effective, if not more effective than prehabilitation. So, but in this talk, I focus on prehabilitation. So, what is the relevance for UMS and HUMS? So, for HUMS, if we implement and we focus on post-operative respiratory complication, which is the one of the most important complication after surgery, we can increase the quality of perioperative care. Okay, for faculty, it is an area of extensive area of education and research, such as fundamental genetic and molecular research on PPC, and more importantly, there has been less study is this subgroup of population which is high risk of PPC, which is sarcopenic obesity. And for HUMS, if we do this, if we increase the prehabilitation, preoperative optimization, and preparation for the patient, it will improve patient satisfaction, staff satisfaction, and clinician satisfaction. It will increase the turnover, so more patient will come, more money can be made, more profit that can be generated. When there is more profit, we can help a lot more patients, and we can help a lot more people in delivering better delivery of healthcare. And this will also in turn increase reputation and of HUMS and UMS as a whole. So with that, thank you everyone for listening. So I pass back to the host.
Hi, Dajaba. Thank you so much. It's very knowledgeable and too comprehensive. Thank you so much. Any question from the audience?
No question.
Seems like so clear, maybe crystal clear. All right. I think it's already more than 9 a.m. also. So